Hello, welcome to the session on liquid biopsies. My name is Aija. I'm the head of Cancer Biomarker Group at the Latvian Biomedical Research and Studies Center. And co-chair is Mary Bernhopf from St.Anna's Children's Cancer Research Institute from Austria. So, liquid biopsies are non-invasive tests for detecting either cancer cells or any cancer-derived molecules in human biofluids, most frequently blood, but these can be other biofluids as well. The applications of liquid biopsies range from early detection of cancer to monitoring treatment response, treatment selection, and early detection of recurrences. Today we are going to hear 4 great talks on various types of liquid biopsies, I assume also challenges with liquid biopsies and applications in various clinical scenarios. So we are going to have a panel discussion at the end of the session. So unless you have a really burning question, please keep your questions till the end of the session, and then you will have an opportunity to ask the questions to all the speakers.
So also welcome from my side, and it's a great honor to introduce to you the first speaker, which is Martin Zoche. He's a real adventurer. He started his career journey after his PhD by moving to the US for a postdoc at Caltech. Then he continued working at industry, including many years at Roche, before he became the director of the molecular tumor profiling at the Department of Pathology and Molecular Pathology at the University Hospital Zurich. He set up the entire facility with modern NGS technologies and is now a well-known cancer profiling expert in Switzerland and beyond. Today he will talk about liquid biopsies in clinical practice. Please welcome with me Martin. Martin, the stage is yours.
Thank you very much for this kind introduction. And I start with pantarai. That's Greek and means everything flows. Everything is flowing, is ongoing. And this is truly the case for liquid biopsy. It's not only the blood, it's also the science and also the diagnostics which will shape in future the patient journey of a tumor patient. And I will bring you a little bit closer what we are doing today already for our patients in the University Hospital in Zurich in terms of liquid biopsy and how we can improve and support the oncologist's decision in terms of when which therapy should be used. So I have 3 parts. Liquid biopsy technology and application is my first part, so I will introduce you shortly to what we are doing and how we measure ctDNA, circulating tumor DNA. I will introduce you to the concept of liquid monitoring, because this is really the new setup that we monitor patients. We do not do only once a liquid biopsy, we do it on a regular basis. And I will introduce you to a patient case of a young breast cancer patient. So as you know, many different types of DNA, proteins, vesicles are flowing in the blood. So that means every cell which run into apoptosis, healthy cells, tumor cells, are releasing all their stuff into the blood vessels. And most of it is cfDNA, that means cell-free DNA, which is circulating in the blood. And now is the goal for us to identify these few DNA pieces from tumor cells, we call it ctDNA, circulating tumor DNA, and sequence these pieces of DNA to understand better what is a tumor profile of a solid tumor, for example, lung cancer, colon cancer, or stomach cancer. In doing so, we use a trick. And the trick is that still in the blood, the DNA is wrapped around histones. So you can have one histone, but you also can have denucleosomes, that means 2 histones are together, or even 3 histones. But typically you have 1 histone. And the circulation of the DNA around one nucleosome is clearly around 167 base pairs. So this is clearly defined. And to distinguish now the ctDNA from the cfDNA, the cfDNA has a 30 base pair shorter circulation of the DNA around the histone. This is due to methylation status, due to other epigenetics, because the tumor cell has a much faster readout of transcription and translation into proteins as normal cells. And this we can use, this change of the length of the DNA we are identifying in the blood to say that a piece of DNA is coming either from a normal healthy cell or is coming from a tumor cell. And with that, we are really able to detect the tumor cell fraction. And we can have a high tumor cell fraction, so if this is a diagnostic result, this is a highly active tumor of a patient who really is in progress. You can have a low tumor fraction, 1% or even below. We can measure up to 0.1%. And you can have the situation, and I hope, for example, that I have this situation and all of you, that there is no ctDNA detectable, and that means that no ctDNA is in your bloodstream. So this is a very important and important tool to identify the tumor fraction, because this is one of the biomarkers we are using for further therapeutic decisions of the oncologist. You can imagine that the tumor cells are spreading the ctDNA differently into the bloodstream. For example, lung cancer patients, liver cancer, they are good spreaders. That means you find a lot of ctDNA in the blood, but you have other tumors here on the right side, glioblastomas. You can imagine immediately that it's very difficult to identify the ctDNA from those tumors, because they have to transmit the blood-brain barrier anyway. Here we are already using a trick now. We are also looking into the liquor, that means into the cerebral spine fluid, and we can detect actually the ctDNA also from the spine fluid. And this is a very helpful measure, because then a brain biopsy is not anymore necessary, for example, for a breast cancer patient who has brain metastasis, or somebody who has a glioblastoma. And we have many cases now, especially for children, where we are using CF liquor as a originating tissue or the originating fluid to identify the right ctDNA from the sample. One big advantage is that in a metastasized status, when the patient has many lesions, the oncologist has a problem: which lesion should I biopsy? Because you cannot biopsy all lesions. And as you know, via tumor heterogeneity, all these lesions might have different molecular tumor profiles. And in the liquid biopsy, because they are all spreading their DNA, their ctDNA into the blood, you're able to measure all important pathogenic mutations at once without going into each and every metastasis. And this, of course, gives the oncologist a very good hint about what is the next therapy step, which mutations should I tackle first and which second. There are studies out which showing that the liquid biopsy is almost as good as tissue biopsy. I really have to say almost, and I will show you where are the disadvantages of liquid biopsy, where simply the sensitivity is not so good, and where we have to rely on tissue. So tissue is still the gold standard, especially also for all the histology, the morphology of the tumor. But then for the tumor profiling, the liquid biopsy is a very suitable measurement. And you have to imagine we have specific patients where either the tumor is not accessible, or the patient is in a medical condition where it's not anymore possible to get a tissue biopsy, and then the liquid biopsy is optimal tool still to give options to the oncologist for treatment. So there is a big study out from Gustave Roussy, and in this study more than 1,000 samples were compared between tissue biopsy and liquid biopsy. This is a very simple clinical set up here. So it was, the tissue was molecular tumor profiled and the liquid biopsy, and then both were compared. And these are the results. And you can see that in green, the nucleotide variants, the single nucleotide variants, are more or less the same, which can be identified in both samples, in liquid biopsy and in tissue biopsy. But you see that in tissue biopsy, the rearrangements and the copy number alteration, that means the amplification, a HER2 amplification in breast cancer, for example, is not so well detected in liquid biopsy. And this is simply to do that we only have very short pieces of DNA. We are sometimes missing the SNPs from that regions, and then it's really hard to, with the bioinformatic algorithms, to identify the right copy number alteration, especially when the HER2 status is equivocal, which means yes, no, it's not a clear amplification of 20, 30, 50, but only 6 or 7 amplified, and then it's really hard to detect the correct copy number alteration. Also rearrangements, especially larger rearrangements, is difficult to detect in liquid biopsy as well. So here the tissue is still the gold standard to detect. Liquid monitoring. So can imagine that you do not do only one test, but many. And so a typical setup is that you have a patient which is diagnosed with a tumor, and then either you can do MRD testing or recurrent surveillance testing with these methods. And then later, if the tumor comes back, if the patient goes into progression, then again you can start with the tissue biopsy and follow up with monitoring. And how looks this in practice? So what we are doing is, for a metastatic patient, with first diagnosis, we take a biopsy and we take a blood sample. And this is, the blood sample is for me the baseline, which I know that this is without treatment the current status of the samples of the mutations in the blood, which typically might differ a little bit. What I have mentioned, copy number alterations, fusions, rearrangements are harder to detect. But then under therapy, we are doing additional tests, and this can be after 2 weeks, after 4 weeks, after 2 months, depending on the status of the patient. Here the oncologist decides. We have not yet guidelines to say that in pancreatic cancer we have to do it every 2 weeks or 3, and in lung cancer differently. We are far too early here. Panterei, we are still in the flow, and these are things which has to be established in the clinical setting. The same for adjuvant treatment. If you have a patient which undergoes a surgery, and then maybe adjuvant therapy, and then monitoring is done, then also the tests are done, and this can be going even over months and years. One patient case I have for you, and this is an invasive breast cancer, 43-year-old woman. And here we see on the very left the tissue biopsy. On the right, at the same time, this happened in May 2024, it was the first diagnosis. You see directly the liquid biopsy taken at the same time as the tissue biopsy. And you see a very nice match of many of these yellow mutations are the pathogenic mutations. The gray mutations or the gray lines are, we call it variants of unknown significance. That means these are mutations which are not clearly pathogenic, but we still don't know. These are not benign mutations. Benign mutations we do not report, but these might mutations which also play a role in the tumor progress. But you can see that these amplifications down here are not measured in the blood. And this is according to what I have told you before, that amplifications are harder to detect. And here we are missing the amplifications. And that means that the tissue biopsy, here you have the HER2 gene with an amplification of 6. So this is borderline. So here it's really on discussion. Herceptin, yes, no. Oncologists are sometimes not in the same opinion when you have these results. And you do not see that in the liquid biopsy. Yeah, so we are missing these mutations. Then we have later biopsies, liquid biopsies, one in June, one in August. And here all mutations are gone. And I will show you why, because the patient underwent chemotherapy and the tumor fraction went down immediately and stayed down. The last liquid biopsy was taken in June this year, as well as the mutations. So the mutations immediately went down and stayed down, and after 1 year, chemotherapy was stopped for this patient, and still the tumor fraction and the mutations, the pathogenic mutations, are below the detection limit. So these are good news for the patient. In the beginning, I always got the call, there's nothing in the report, you haven't reported anything. And I say, yes, these are good news for the patient, because we could not detect any pathogenic mutations, which is good for the patients. If we detect, then the next line of therapy mainly is under discussion. You see here two. These are variants of unknown significance, but for illustration, I have brought them here into the picture. And you see here that these two mutations are staying at 50% variant allele frequency. And these are simple germline mutations, so they will never go away. And that means if, for example, we have in a case with a BRCA mutation, a patient where we see in tissue a BRCA mutation, today we are not even discussed with the patient that there might be a germline mutation laying behind. We are waiting for the first liquid biopsy, and if we do not see the BRCA mutation on 50% variant allele frequency, we do not even discuss the possibility of a germline mutation with the patient, because most likely there is no germline mutation in this patient. But if we see that in the liquid biopsy, then we know that further human geneticist counseling has to be done. So this is now our current status, how we treat our patients. And for metastatic patients, all metastatic patients receive liquid biopsy immediately. And also the monitoring, this is somehow also very difficult sometimes in terms of reimbursement, but we are in discussion here with the health insurances, and in Switzerland we have a quite comfortable situation that the health insurances are paying a lot of these tests, so therefore it's a very comfortable situation for patients that they can receive nowadays these modern methods of diagnostics for cancer therapy. Thank you. If there is any direct question to this talk, I would like to ask you to bring it up, because I have to run now to the airport and I'm not around anymore for the panel discussion, so therefore maybe you can
are there any questions? If not, I can ask the first one. So if you would speculate where liquid biopsies will be in 5-10 years, do you see liquid biopsies replacing a clinical standard practice that we are currently doing, for example, for screening, for disease monitoring, or will it always be complementary to what we are currently doing?
It will not replace, so the tissue biopsy is still gold standard, and I do not think that the pathologist would not want to have a tissue biopsy. And clearly you have to do many IHCs or the prognostic markers, etc., which has to be identified from tissue. So tissue is still the gold standard, and this will not go away. So a biopsy is still a must. But the liquid biopsy will come in addition to monitor better the patients. Regarding screening, if you're talking now about screening of healthy people, I do not believe that we will see these kind of liquid biopsy, that you are looking for pathogenic mutations to the patient, as a screening tool. Why? And this is, I haven't talked and I have not shown. There is a mechanism called clonal hematopoiesis. That means we are all acquiring mutations in specific genes, for example, TP53, DNMT3A, ATM, all pathogenic genes, many of them in the HRD pathway. Also pathogenic mutations. So we easily can have a TP53 pathogenic mutation with a variant allele frequency of maybe 1%, 2% in our blood without having a tumor Yeah, so we are completely healthy. We are only acquiring this because these are more or less somatic mutations. And if you now have a test and you want to look if somebody has a tumor, you're looking exactly for these pathogenic mutations, and therefore we cannot go for it because then we would have many, many false positives. So that means for screening of healthy people, and I think everybody is eagerly waiting for these kind of screens. You go once a year to the doctor, 5 milliliters blood, and one week later you know if you have a cancer somewhere or not. There we will go to epigenetics, methylation or fragmentation of the whole genome. These kind of tests, I think, are more promising today to give good results in terms of screening. But for patients where we know already that they have pathogenic mutations, this is a perfect way to analyze and to see the current status of the patient and if new therapeutic lines have to be introduced.
Many thanks. Are there any other questions from the audience? I don't see any hands up.
Okay.
So thanks again, Martin.
Thank you.
Have a safe flight back home. And it's a great pleasure to introduce our second speaker, Kendra Maaß. Kendra studied in Heidelberg and dedicated her work soon to brain tumors and liquid biopsies. She focuses on not only cell-free DNA, which she will talk about today, but also extracellular vesicles, for which she established the Rhine-Neckar Extracellular Vesicles Group. For almost 6 years, she has been a junior group leader for cancer prevention and liquid biopsies at the Hopp Children's Cancer Center and University Clinic Heidelberg. And she will give us now insights into liquid biopsies at kids, early diagnosis, therapy monitoring, and surveillance. Please welcome with me Kendra. Kendra, stage is yours.
Yeah, I would take the opportunity to thank the organizers for inviting me here and giving me the opportunity to share our experience in establishing, implementing, and also using liquid biopsy technologies in the pediatric setting, which is slightly different than what we have just seen. And I think since Martin already nicely introduced the principle of liquid biopsies, I can directly jump to the specific challenges that we see in pediatric oncology. So often enough, we have very low sample volumes. We have low mutational burden, so the test that was just presented from Martin would not capture the complexity of the disease. We have a very highly heterogeneous tumor diagnosis set. Most of them are rare diseases, and we have very few recurrent targets. So the findings from adult oncology, as presented now, cannot directly be applied. On top of that, often enough, pediatric studies are performed in a decentralized setup, so the patients are seen in various sites across Europe. So when we started with liquid biopsy technologies, first we looked into the pre-analytical considerations, and we focused specifically how can we stabilize biomarkers, but also minimize contaminations from healthy microenvironment, and most importantly, how can we get reproducible sampling conditions that we really can draw clinical interpretations from the liquid biopsy data. Today I would like to present what we have found in the liquid biopsy field along the clinical line of a pediatric oncology patient. And historically I would like to start at the end of this road with the Inform Precision Oncology program, where we had the chance to also collect plasma samples on top of the comprehensive molecular setup that is done on the tumor and germline. We have collected 130 plasma samples across diagnosis with a majority of brain tumors, sarcomas, and other tumors. Directly after isolating the cell-free DNA, we observed significant differences with solid tumors shedding more cell-free DNA into the circulation than the intracranial ones and some others. Depending on the cell-free DNA material that we had, we aimed to compare different sequencing technologies, namely low-coverage whole genome sequencing, whole exome sequencing, and a pediatric panel for specific alterations. And today I just want to highlight the added value of low-coverage whole genome sequencing after having heard about the panel discussion, panel sequencing. I also jump over this because you already learned about the specific features of cell-free DNA and the fragment length that can be leveraged. We also had, seeing after sequencing the exact length of a genomic segment, we took advantage of this, and I want to highlight how this then affects the results of a whole genome sequencing data. So on top, you see the copy number profile of the tumor of the patient, and below the plasma profiles of the cell-free DNA. And you can appreciate that the copy number changes are recapitulated, but nevertheless with a much lower amplitude and sometimes hard to detect. But if we now zoom in on the cell-free DNA fragments that Martin earlier introduced as ctDNA fragments, you can take this information and only look at the short fragments and highly amplify the signal coming from the tumor. We even went one step further and segmented the whole genome into regions of amplifications, gains, neutral or losses, and quantified how many of these genomic segments fall into this shorter DNA, cell-free DNA. And we could see that especially regions of amplifications and gain are highly significantly overrepresented in the pool of ctDNA. With this finding, we integrated the fragment length and the copy number status and looked into the informative value of each of the features. When just looking at the short fragment range, the short fragment amount, so the ctDNA, we could see that with low significance, we could separate low tumor burden patients from healthy controls. But integrating now all these features that I presented to you before, even brain tumor patients were very distinct from healthy controls, so the integration of several features being inherited in these ctDNAs help. And I think it becomes more visible when you look at the sensitivity and the specificity of a test. So the dark green line represents, if you look at the entire pool of cell-free DNA fragments, and the light green, how you can increase both the sensitivity and specificity of a liquid biopsy test by zooming in only on the short fragments. On top, if you look at brain tumors, I think it's quite impressive that also those diagnoses are detectable in plasma. One case I want to highlight is where liquid biopsies can add to the standard tissue biopsy is a patient with a bilateral Wilms tumor being already presented with metastatic sites. And when we compared the tumor to the plasma, it became apparent that they don't overlap and show not much overlap between the copy number variations. We went back to the treating center and could see that from the various tumor sites, the plasma represented best the Wilms tumor from the right side, while in the tumor board of Inform, the Wilms tumor of the left side was characterized. So we can really see that these liquid biopsies have an added value that can be extracted and also highlighted by the prognostic markers of loss of heterozygosity on chromosome 1 and 16 that was detected in the plasma but not in the tumor biopsy discussed in the tumor board. This technology can also be applied in the monitoring setting, as highlighted here for an alveolar rhabdomyosarcoma patient, also with primary metastatic tumor. The standard of care would be an MRI imaging monitoring every 3 months. And for this patient, after 9 months, progressive disease was detected. By now adding liquid biopsies in a much smaller interval, first of all, we were able to show the minimal residual disease at all time points with the advanced bioinformatic tool, but also the progressive disease 2 months earlier than the standard MRI, and this would allow us to increase the window of opportunity. We can also use the liquid biopsy assays for MRD detection, and I just briefly wanted to show you how this affects brain tumor patients with the diagnosis of medulloblastoma, highlighted here for one patient with an initial tumor profile, initial CSF profile that was still positive. The tumor was not detectable after 12 months, but after 18 months, the characteristic tumor changes were again visible in the liquids, while the MRI was 3 months later. But most importantly, if you now apply this on a larger cohort in a standardized setting, what we learned is, if you look at the prognostic value of this MRD positivity from the liquid biopsy data, at baseline, meaning at day 14, which is a standard time point for medulloblastoma, the value was not that predictive for progression-free survival. But when we looked at the mid-chemo time point, it actually separated the groups of responders and tumor-free patients much better. Last but not least, I want to bring you a technology that includes now also the methylation, as Martin mentioned earlier, in the early diagnosis of brain tumors again. And you might be aware of the methylation-based classification of brain tumors, and there is a variety out there now, but I think the most important take-home message is that we have a high granularity, and we can use these methylation patterns for a robust classification. The main problem is a lot of these technologies require a lot of material, which we usually don't see in liquid biopsies. So the first step was to adapt methylation profiling to low input amounts. And usually you would go in with microgram of tumor-derived material, but we started with 50, 10, 500, 0.5 nanogram, and even went down to 100 picogram. And with a new enzymatic conversion, in contrast to the bisulfite conversion, we could see that we can actually recapitulate the CNVs with a slightly lower quality. And to show this on the right side, the tumor CNVs were actually confidently called even down to the 100 picogram. But you can also zoom into more specific sites in the genome you might be interested in, such as OTX2, important transcription factors, and the methylation status of a given genomic segment, as you can see here, is also inherited even down if we start with 100 picogram of input material. As we also learned in Martin's talks, liquid biopsies is not only about limited material, but also about varying tumor fractions that have a heavy impact on the results of a liquid biopsy test. So we also titrated how much tumor load do we need that this methylation-based assay actually works. And just for the CNVs, I can show you that down to 5%, we can see the copy numbers from the tumor, and the methylation sites even lower at below 1%. We now teamed up with a multi-institutional cross-entity cohort to get CSF samples from 255 patients and did magic by imputing missing values and training a neuronal network to really come up with a novel methylation classifier that works on the specific requirements of liquid biopsies. And then the final output of the classifier is that on the one hand, you get the methylation classification as you would get for a standard tumor classifier, but also a cell type prediction and the composition of your cell-free DNA pool. Having done so, we were able to successfully classify 90% of the patient samples from CSF liquid biopsies. We have done this with Illumina sequencer, but this technology is actually not limited to Illumina sequencing. We could also show that this classifier can equally work, or it can also work with nanopore sequencing data, but also with the array technology, with the limitation that low tumor burden and low material you lose, or some samples are not predictable. But I think this is still worthwhile following up with other platforms. As I mentioned, we do not only get the tumor classification, but we also get the composition of the cell types that contribute to a given cell-free DNA pool. On the left side, you see what cell types contribute to a non-oncological CSF, which we collected from patients without a tumor disease, but also to highlight the variability here on the right side for medulloblastoma subgroups, where you can see varying ratios of oligodendrocytes, B cells, or astrocytes that contribute to the pool. And what we can do with this, I think that will be content of further studies. Last but not least, I also brought some patient examples where we can really use this technology in the best interest of our patients. So one case is how we can use this classifier MPEG for treatment monitoring with a group for medulloblastoma, flat genome, as you can see for the tumor, that was recapitulated in the CSF after surgery with a 67% tumor content, and post-radiation and 9 months of therapy confirmed the imaging diagnosis of no residual tumor left. But it can even go one step further. So if a tumor evolves over time or secondary malignancy forms, this classifier also allows to predict the secondary malignancy, as highlighted here for a Wind medulloblastoma that evolved into a GBM. Last but not least, even at the granularity of tumor evolution, this classifier has a value, as shown here for a group for medulloblastoma, that post-surgery was still detectable with the correct classification and further evolved 15 months off therapy to a group 3 medulloblastoma with a quite high tumor content. And with this, I would like to end, and I hope that you could see that we worked the last years to really establish robust and standardized protocols that make liquid biopsy, or that pave the way to clinical implementation. Especially for brain tumors, we started an initiative within the SIOP umbrella together with Johannes Goyo to really be a consultant for everybody who would like to start with this, provide hands-on trainings that everybody does not reinvent the wheel and can just benefit from the knowledge of the crowd. We also worked on standards, how CSF collection should be implemented in clinical trials with various quality values, let's say. Also important for the implementation in clinical trials, we ask patients, how do you actually perceive liquid biopsies? Would you be willing to add this additional burden of a lumbar puncture or CSF collection, but also to inform the patient what will be done with your material? And they were quite supporting that this technology can help the clinical management of brain tumors. And the last point is more an outlook that the technologies that we have developed, I think they open a lot of opportunities in the setting of innovative treatments such as CAR-T or TCR treatments, where also the immune composition might have an informative value, and that also other biomarkers, as we also heard later in this session, might be very important to look at, such as protein vesicles, etc. And with this, this was obviously teamwork, and thank you for your attention.
Many thanks to Kendra. So if you have any questions, please write them down. And we will discuss this then all together in the discussion afterwards.
And now it's my pleasure to introduce my co-chair, Mary Bernhopf from St.Anna's Children Cancer Research Institute from Austria, who is going to present an update on MONALISA clinical trial on use of liquid biopsies for detecting neuroblastoma relapse. So the floor is yours.
Thank you very much for the introduction. It's a great pleasure to stand here again, to actually stand here, because last year I was already presenting the whole idea of MONALISA, but I missed my flight, so you only saw a video of a recorded video then in the end. Yeah, I'm happy to give you an update after another year of working hard on this project called MONALISA, a SIOPEN pragmatic clinical trial to monitor neuroblastoma relapse with liquid biopsy sensitive analysis. And before we dive into that, just a few words about neuroblastoma. It's a tumor of the embryonal cells of the sympathetic nervous system. The primary tumor mainly occurs at the adrenal gland region. It's the most common solid tumor in young children and toddlers, with about 1,500 children being diagnosed per year in the EU, and it accounts for 15% of deaths in children with cancer. It's a very heterogeneous disease on the one hand from a biological point, but also from a clinical course, where you have on the one hand the low-risk disease with spontaneous regression, and on the other hand the high-risk disease with metastasis mainly into the bone marrow, very specific genetic alterations, and the 5-year survival rate below 50%. And that is due to the fact that 60% of patients with high-risk neuroblastoma have a relapse within the first year of treatment. And when this relapse occurs, the survival rates are very low, below 10% of these patients can be cured in the end. And that is actually despite the very intensive multimolar treatment over 1.5 years, and that is an example of the SIOPEN high-risk neuroblastoma 1 trial, where you have induction chemotherapy, you have radiotherapy, immunotherapy, surgery, and so on. And during that time, during the treatment, the response evaluation and also the follow-up monitoring is according to international standards, and that is on the one hand nuclear imaging, MRBG, and also MRI, and also bone marrow response assessment. And that is done every 3 to 6 months. It's quite invasive, as you can imagine, the bone marrow analysis, and also burdensome. So the young children, they can't just be in an MRI without anesthesia. So there is a clinical need for better and also less invasive markers, and we are very convinced that these are liquid biopsies. And we can be so convinced because we have a lot of retrospective data and studies in the neuroblastoma community already published. I will not go into details of this now, but in the end we joined forces for the MONALISA project. And that is the first trial that now prospectively evaluates the liquid biopsies in a pediatric cancer, and the first one that will also base clinical decision-making on liquid biopsies. And that's a picture of our kickoff meeting already from January 2024. And so the aims of these projects are on the one hand to establish a pragmatic randomized clinical trial for patients with relapse neuroblastoma, to perform then real-time liquid biopsy testing within this trial in order to detect a relapse earlier. We will also support the trial by building a historical cohort by summarizing and analyzing all these retrospective studies and data we have. We will develop databases and also a digital decision support tool to help oncologists use the new monitoring. And very importantly, we will assess patient-reported outcomes and quality of life, something Kendra already mentioned, how are liquid biopsies perceived. And the long-term objective is to establish liquid biopsies as standard of care. So about the clinical trial design, we will include patients with high-risk neuroblastoma, a diagnosed relapse, and at least stable disease and no active treatment trial. There will be 150 patients randomized into 2 arms. On the one hand, we have arm B, which is the standard of care monitoring I've just described before, so the imaging and the bone marrow assessment. And then in arm A, there will be additionally also a monthly liquid biopsy test being performed and real-time reporting. So the recruitment will be for about 3.5 years, and the primary objective is to investigate whether liquid biopsies may detect an imminent relapse or a progression earlier through either a rising new liquid biopsy signal or an increase in signal, and we call this a molecular event. So the update here is that we completed the clinical trial protocol, the patient information and informed consent form, so that was huge work by work package 2 and 8 leader Lieve Titkat from the Princess Maxima Center. We have ethics approval in the Netherlands as the sponsors, so there will be hopefully soon the first patients being recruited, and many more countries will also go through the ethics approval as we speak. About the laboratory workflow, so we will get blood tubes from the patients, so peripheral blood tubes on the one hand in PAX-gene tubes to isolate mRNA, and do a qPCR for the detection of FOX2B and TH, so these are markers in neuroblastoma. And then we will also receive an EDTA tube from which we will isolate plasma and then circulating tumor DNA. And we will run, on the one hand, NGS panel. It's a custom panel in our case with about 120 genes that are relevant in neuroblastoma, and also a ddPCR for McN and ALK copy numbers, so McN amplification and ALK hotspot mutations, which are the most recurrent mutations in neuroblastoma. And the update here is that we've worked very hard on the workflows for the shipment, because there are 7 reference labs, but more centers that will open, and it's kind of a matchmaking, who is sending to which reference lab. We have also established the quality-controlled assays that are EU IVDR compliant and are mainly performed in ISO 15189 accredited laboratories. We have harmonized the SOPs for sample preparation for the actual liquid biopsy tests and also for the clinical reporting, and that work was led by Work Package 3, and Sabine Taschner-Mandl from the CCRI was the leader for that one. And one question that we talked about a lot in the last few months was about the clinical interpretation and how do we define a molecular event in Arm A, where we do the in real-time liquid biopsy testing and reporting. And so there are different outcomes. On the one hand, we either see no change in signal or a decrease in signal, where we would report no indication of a molecular event and would advise to continue monitoring. On the other hand, there is an increase in signal or a new signal, and if you would see that, we would report an indication of a molecular event and would advise to perform disease assessment. And there's obviously also the option that there is an unclear result, and we would advise to repeat or await the next liquid biopsy, which will be another month's time anyway. So in order to define all this, we established expert working groups for all the three technologies, so the NGS, the ddPCR, and the qPCR, and we went through different scenarios. For example, for the NGS, that would be what are we going to do and how are we going to report it and interpret it if we have variants that are all below our threshold that we set, as in scenario 1. Or what if the variant signal increases slowly, so not from one time point to the next one in a month's time, but over 2 months' time? Or scenario 3, as an example, what if one variant signal goes down and another one goes up? So how would we interpret all this? And so we came up with more out of a gut feeling suggestions, and we defined the interpretation and the reporting guidelines there. We summarized this in decision trees and SOPs and the lab manual, and we will hopefully publish this also soon. Maybe it's a blueprint for other liquid biopsy clinical trials. Further achievements, we also made an inventory of the retrospective liquid biopsy data, so that is work from Work Package 4, led by Hedi Deutzer. Then we developed the clinical database. We extended the existing biological databases that already exist for neuroblastoma, and we also created this link to the UPID service. I'm not sure if you're aware of that, but this is this privacy-preserving European patient identifier, and that work was led by Work Package 5 leader Gudrun Schleiermacher. And as I mentioned before, the development of the questionnaires and the web application for patient-reported outcomes and quality of life, so that is Work Package 6, led by Vasilios, and we had huge support as well, and a lot of help by our patient advocates, Leona and Nick, and that is basically how the families also perceive this going to the clinic or basically being confronted every month with the disease and how this is perceived and if this is causing a lot of stress as well. I think this is something we always need to consider as well in the liquid biopsy field, because we can do a lot of things in the lab, but how it will be perceived and what it will cause for the families is also very important to consider. So these are the project highlights. To summarize, MONALISA is the first trial prospectively evaluating liquid biopsies in pediatric cancer, and the first one that will base clinical decision-making on liquid biopsies. We will randomize 150 patients with relapse into standard follow-up versus standard follow-up plus monthly liquid biopsy testing. Those tests will be performed in 7 reference labs across Europe according to EU IVDR, and will be very comprehensive. So on the one hand, we will analyze adrenergic mRNA using qPCR. We will analyze ctDNA with ALK, MIC-N, and an NGS panel where we will detect the changes in the signal and also therapeutic targets like the ALK mutations. We will also develop links to the trial databases, a clinical decision support tool, and a quality of life reporting app. And this is because of a huge effort from a big group of 24 partners in 11 countries. There's the coordination team from SIOPEN and the scientific coordination from PMC and St.Anna. There's the project management team and all the partners that are involved. It's a real pleasure to work with so many enthusiastic liquid biopsy people. There is more information for you. On the one hand, the website, but also the patient app that is already ready to go and established. And there is a video that summarizes the whole project. And let's see if we manage this.
Every year, around 20,000 children and adolescents in Europe are diagnosed with cancer. Today, about 80% of these children survive. But when the cancer comes back, survival chances can drop dramatically. This is the case for neuroblastoma, one of the most aggressive childhood cancers. Because neuroblastoma is rare, international collaboration between researchers is essential to improve diagnosis and treatment. To give children the best treatment options, it is important to closely monitor their disease and detect a potential return of the cancer as early as possible. But how can we detect relapse earlier without putting children through stressful, invasive tests? Lisa, diagnosed with neuroblastoma at the age of 3, was considered cured. Like any parent, Lisa's family dreams of a normal life, but the fear of relapse lingers. Every 3 to 6 months, Lisa undergoes scans and a bone marrow test, an invasive and anxiety-inducing process, which is a burden for Lisa and her family. What if the cancer returns, but they don't know until the next checkup 6 months from now? Is there no other way of monitoring Lisa's cancer? Then, Lisa's doctor introduces a new possibility: liquid biopsy. This method, essentially a blood test, can even be done at home, allowing for more frequent monitoring without the burden of the stressful and invasive tests. In the lab, the blood is analysed for small traces of tumour DNA, or mRNA, genetic material released by tumour cells. If detected, it may indicate the cancer is coming back earlier than the scans and bone marrow tests would have shown it. The European Union-funded project MONALISA, launched in 2024, is stepping forward into making this a reality to all children with relapsed neuroblastoma and beyond. If these blood tests can be analysed directly in hospital labs and at any moment without needing stressful tests, a diagnosis can be reached sooner. Lisa's parents are of course anxious to know the results. MONALISA is also collecting information about the emotional stress that patients and families experience, helping hospitals to better understand the psychological impact of frequent disease monitoring. This project includes a clinical trial with 150 patients across 11 European countries, with 24 partners from clinical research centres, diagnostic labs, private companies, and patient advocacy groups. MONALISA is helping to bring liquid biopsies into standard care, ultimately aiming to improve the overall survival rates of neuroblastoma patients. MONALISA, the future of cancer monitoring starts now. For more information, visit the MONALISA website.
Thank you very much for this very great, clear talk and inspiring video. So please keep your questions till the end of the session. And thank you once again for your talk. And now we are going to switch gears to an alternative, emerging type of liquid biopsies. These are extracellular vesicles. And I would like to welcome Agnese Brokāne, a PhD student from the Latvian Biomedical Research and Study Center, who is going to talk about extracellular vesicles in liquid biopsies as biomarkers and functional readouts for cancer detection. So the floor is yours.
Right. Thank you for the introduction. Hello. And yeah, so we just heard some really great talks on nucleic acids and their use in liquid biopsies. And I wanted to give you some insights in a maybe smaller player in this liquid biopsy field, which are extracellular vesicles and how they could be used for cancer detection. And also share some of the work me and my colleagues at the Cancer Biomarkers group in the Latvian Biomedical Research and Study Center have been working on for the past few years. So very briefly, extracellular vesicles, or EVs, are small particles that are enclosed by a lipid bilayer, and they are secreted by almost all cell types in the body, and they are very stable in the extracellular environment. They transfer information from their parent cells to various recipient cells throughout the body. So the thing about EVs is that they are heterogeneous, and they are mainly categorized by their size, biogenesis pathways, and surface markers. And and these surface markers can be different kinds of molecules, such as tetraspanins, which could be characteristic of their parent cells, as well as other components of the cell membrane. And enclosed in EVs, we can find nucleic acids, proteins, lipids, and different metabolites. So the great thing about EVs is that they are released into almost all types of body fluids, including plasma, urine, saliva, cerebrospinal fluid, and more, which makes them an extremely versatile and minimally invasive source of tumor material for liquid biopsies. So the idea is that once a patient sample is collected, tumor EVs can be isolated, and they carry a rich multi-omic cargo, such as RNAs, including messenger RNAs, long-non-coding RNAs, or microRNAs, DNA fragments that could reflect tumor mutations and methylation patterns, as well as proteins, both on their surface and inside. And to determine cancer signatures, molecular analysis tools such as PCR or NGS for RNA and DNA markers, or mass spectrometry and immunoassays for protein markers could be used. And all of this, the end goal is to translate these vesicle-derived signals into clinical tests using the simple liquid biopsies. And so globally, interest in EVs has absolutely skyrocketed over the past decades, and the number of EV biomarker-related papers has considerably increased. And there are already more than 70 registered clinical trials testing EV-based diagnostics across different cancers. So it's very clear that the field is moving from basic discovery towards real clinical use. But so how do EVs compare to today's gold standards in liquid biopsies, which would be circulating tumor DNA and circulating tumor cells? We would say they fit somewhere in the middle. They are highly abundant in comparison to CTCs, which can be rare and also tricky to isolate. And they are also remarkably stable thanks to their lipid bilayer, and they carry this multi-omic cargo that reflects live tumor biology. Unlike maybe ctDNA, which can be just fragmented and DNA, or could be scarce in early disease. But the main problem for EVs is that tumor-derived vesicles are often mixed with a very large background of normal vesicles, and also that there is no gold standard method of isolation yet. But either way, having seen this promise of EV cargo as a rich source of tumor signals, our group focused on systematically profiling EVs in patient biofluids to discover and validate RNA biomarkers for different types of cancers. And we started with prostate cancer, and what we did is we wanted to we began by sequencing RNAs from matched tumor and normal prostate tissues, and also from plasma and urinary EVs collected before and after radical prostatectomy. And our filtering strategy looked at RNAs that were overexpressed in tumor tissues, present in pre-surgery EVs, and also decreased after the surgery, which indicated their true tumor origin. And well, looking at urinary EVs on the left side of the diagrams, we identified many potential EV-enclosed biomarkers representing various RNA biotypes, two of which we can see here, that also tracked with the tumor and decreased after their removal. Plasma EVs, in contrast, yielded fewer candidates, and well, to us this showed urinary EVs could be a better reservoir of prostate cancer-derived transcripts. And we then we then chose some of the most promising biomarker candidates, and we wanted to validate them in a larger independent cohort using digital PCR. And for urinary EVs, we could see a significant urinary EVs and one plasma EV RNA. We could see a significant drop after surgery, for microRNA 375, which indicated that these transcripts truly came from the tumor. For plasma EVs, however, they showed greater potential in discriminating between prostate cancer patients and patients with benign prostate hyperplasia. And among these, two mRNAs, NKX3-1 and GLO1, performed the best in plasma, reaching area under the curve values of up to 0.02 individually, and they actually performed even better when combined, reaching AUC values of 0.05. And the important thing that we actually discovered was that PSA alone, which is currently the standard blood test in for prostate cancer monitoring, which measures prostate-specific antigen, showed much lower discriminative power. And together, these studies showed how we can move from unbiased EV-RNA biomarker discovery into already clinically meaningful panels. And after establishing this EV-based biomarker workflow in prostate cancer, we turn to breast cancer, another area where tissue biopsies are often invasive and may not capture tumor heterogeneity. And in a longitudinal study, we profiled plasma EVs from breast cancer patients before and after surgery, and also throughout neoadjuvant chemotherapy, to identify diagnostic and treatment-responsive RNA biomarkers. And the first thing we saw was that EV concentrations actually followed clinical events, being the highest right before surgery, remaining elevated a week after, and then returning to cancer-free levels by 6 months. So the other thing we looked at was how these transcripts compared when comparing pre-operative plasma EV and healthy controls, and also we looked for a drop after surgery. And we saw a number of differentially expressed RNAs in a number of RNA classes, and some of which even reached AUC values up to 0.05. Up to 0.75. And we saw that they showed very high specificity, however, they often had limited sensitivity. We were able to construct an 8 RNA biomarker model using logistic regression, which could differentiate breast cancer patients from healthy controls with an AUC value of 0.9. Then we wanted to look at whether EVs could hold information about how breast cancer patients would respond to neoadjuvant chemotherapy, and we actually discovered multiple EV RNAs that were elevated in patients who were non-responsive to neoadjuvant chemotherapy already at the point of diagnosis and throughout therapy, suggesting a potential early blood-based predictor of poor therapy response and relapse risk. And together, these studies showed that EV RNA cargo can inform both diagnosis and treatment response in breast cancer. So, what we learned is that so we did discover many promising EV-derived RNAs, and while their specificity was often excellent, their sensitivity was limited, especially when tested in larger or independent cohorts. And combining markers into multi-RNA panels could improve diagnostic performance, but validation was often challenging because of EV heterogeneity and different technical variations. Going forward, one thing is that we could focus on capturing tumor-specific EVs, for example, through surface markers, and also adapting more sensitive analytics, such as a single EV flow cytometry, digital assays, or microfluidics, in order to sort of really find these hidden signals. So we've seen that EV cargo can reveal valuable tumor signals. However, the thing about EVs is that they're not just passive carriers, and they are in fact very active messengers in the tumor microenvironment. And by carrying bioactive molecules between tumor stromal, immune, and endothelial cells, they can reprogram fibroblasts, promote angiogenesis, remodel the extracellular matrix, suppress anti-tumor immunity, and prepare pre-metastatic niches. And so this is the EV-mediated crosstalk that drives tumor growth, invasion, and therapy resistance. So we thought, what if instead of trying to identify individual EV-enclosed biomarkers, we would instead look at EVs as complex entities that combine effects on different tumor microenvironment cells and try to somehow hijack these messages. And the idea and our goal was to determine whether it's possible to detect these cancer EV-induced changes in an in vitro system using cells as biosensors, and to then use these effects for cancer diagnostics. And the first thing to do was to isolate a lot of EVs and also characterize them from colorectal cancer patient and healthy controlled blood plasma. For our biosensor cells, we use dermal fibroblast line HS68. As in our previous experiments, we saw that they showed excellent EV uptake efficiency, with almost all cells taking up or binding to EVs, and they were also highly responsive to cancer cell EV signals. Next, we performed RNA sequencing of these fibroblasts after exposure to cancer patient plasma EVs versus healthy control EVs. And then, to ensure that the signal truly came from EVs, we excluded genes that were also induced by plasma proteins, and then subsequently overlapped our data with changes seen from SW620 colorectal cancer cell line EV exposure. So together, this process yielded a number of cancer EV-regulated genes that represented the cell's response to tumor-derived vesicles. And we then validated the top candidates in an independent cohort. And so far, 2 genes have shown robust upregulation in fibroblasts when exposed to cancer patient EVs as compared to healthy control EVs with high AUC values. And although testing is still currently undergoing, Well, we believe this demonstrates a proof of concept that instead of having to hunt for single cargo molecules, we can actually use the recipient cell's transcriptomic response as a functional biomarker readout. I think today, hopefully, I have shown you that EVs are a rich and stable source of tumor signals for liquid biopsies, that our EV cargo-based studies in prostate and breast cancer have produced highly specific markers, but sensitivity still remains something of a challenge when moved to larger or independent cohorts. Measuring the functional impact of EVs on recipient cells provides an alternative and potentially more robust diagnostic strategy, and that going forward, coupling this functional approach with tumor-specific EV capture and single EV analysis could enable reliable, clinically actionable tests. So thank you for your attention, and first and foremost, I would like to thank my supervisor and PI, Professor Aija, without whose guidance and insights this work would have not been possible, and also a sincere thank you to all my colleagues at the Cancer Biomarkers Group and our clinical and institutional collaborators, and of course thank you to all the patients and families who made this research possible. Thank you.
Thank you, well done. So, and now I would like to invite all the speakers back to the stage.
I can ask the first question if there are no questions from the audience.
Well, probably there are. No, it is time to bring up all your questions that you had during the talks. So,
Don't be shy.
yeah.
Thank you very much. Those are wonderful talks. I've got a question for Kendra. It's a two-part question as a neuro-oncologist. The first part is, where are we with the blood detection of these cancer molecules? Because having children undergo lumbar punctures is not easy, having done it for 20 years. My second question is, with the advent of more rapid sequencing technologies for medulloblastoma, it's possible during the surgical procedure one day to know that the patient has a group 3 medulloblastoma before they even get out of the OR. And what is the sensitivity of looking at the cerebral spinal fluid from an Ommaya reservoir versus a lumbar puncture? Because one could imagine a case where we're putting Ommayas in children up front with aggressive forms of disease, and we can utilize that instead of serial lumbar punctures.
Yeah, very good questions. So to start with the first question that was about the blood-based detection. So as I showed in the first part, so if we have a highly aggressive disease as in INFORM, we have the chance to detect tumors in the blood, but the information value is rather low, so the granularity of information. And I think depending on what information you would like to achieve from the liquid biopsies, I would always recommend the CSF over the blood until our technologies further improve. For the second part of the question, regarding the lumbar puncture versus Ommaya and intraoperative, that was actually one part of the SIOP initiative to really compare different CSF sampling sites, because in contrast to blood, where we have just a peripheral blood sample, CSF sampling site might have a major impact on the sensitivity and specificity of a given assay. And I think the good news is the high-grade glioma trial actually implants Ommaya reservoirs for CSF liquid biopsies for the pure purpose of it. And I think that will really show how we can add this information to the clinical management. And our experience when asking the patient survey was that a majority of patients was quite supportive even for having an added lumbar puncture just for the pure research setting with the direct quote, if it helps, because often enough we don't have any other opportunity for those patients, unfortunately.
There's another question here, and then here.
Can I? Yeah. Okay. Thank you very much for very interesting presentations. Since it's not my field of expertise, so apologies in advance if the question is not very relevant. But if I understand correctly, there are loads of details which affect right interpretation of the results, which I could call biases or hallucinations for clinical purposes. Are there any efforts for international standardization or kind of benchmarking, at least to make sure that efforts taken in different clinical or research organizations are somehow navigating into more unanimous international practice? Because I hear the same problem not only in what you were presenting here, but same with, let's say, microbiome analysis. A lot of differences simply due to the methods used to extract the data or data manipulation afterwards for modeling. Thank you.
I mean, I can start from the pediatric side, maybe. So I think this is often a very political question. So each entity or each study group has their own protocols and they don't want to really change. And I think, at least for the brain tumors and CSF, we really wanted to come as an umbrella organization, come up with standards that not every study group has to start from scratch. So that is for the CSF, and we really hope, and I think we are positive, because everybody is quite thankful that we provide these SOPs that they can just follow and they don't have to test before. And I think for plasma, we, again, for the pediatric field, I can only speak, also for the sarcomas, there are the same initiatives that people come with their different protocols and test how the assays actually perform and compare in round-robin tests. And they also include pre-analytics to really come up with standardized SOPs. And I must also say our experience, despite having this pre-analytical study to start with, where we had preservation tubes and many various aspects in it, we now, for clinical implementation, simplify the protocols massively because we realize not every clinic has the tubes at hand and they expire quickly, etc., etc. So we go back to very simple spins, just get the cells out of the plasma and good quality sample.
It's a very good point. So I think that in clinical trials like the MONALISA, it was actually a prerequisite that the labs are providing EU IVDR compliant tests. So this implies that you have some quality control standards and so on in the laboratories. And we do also perform round-robin sendings or sample exchanges as you said, in the kind of consortia and groups that work on certain tumors, but I totally get your point that it should be across tumors and not the usual bubble we are in. There are ISO standards out there for example, for RNA isolation plus then, so RNA isolation from tumor, from FFPE, for cfDNA, as well for doing NGS later. So there is, at least in the German ISO standards group, they are developing those guidelines. But these are guidelines, they are not binding, but I think it will come more and more also into research projects and clinical trials that you will only get EU funding if you prove that it's done at least according to some sort of standards and guidelines, and that you have those quality controls in place. Because otherwise we will always run into the problem, how can we compare the data? I mean, there was this session on big data as well. How can we compare the data? How can we bring actually all those technologies into the clinic at some point? And it will always be like this. Do we follow the same protocols? And can we compare results? Yeah.
Maybe to add one last point, so there's also a European Liquid Biopsy Society that has various working groups directly addressing your point, and they also heavily or closely work with biobanks, etc., also with eye on retrospective samples, etc., what needs to be considered when you want to perform a liquid biopsy test. So I think that is also a very good address to ask such questions cross-entity.
There was a question over there.
Yeah, okay, hi, sorry. Thanks a lot for the great talks, guys. My question has to do with MRD, I guess, and the clinical trials. So are there any clinical trials in brain tumors where they're going to use this MRD to change treatment, or other entities where you would do like you do in leukemias, where you use this as a real MRD for treatment determination and high-risk stratification?
So I think the upcoming PMNET medulloblastoma trial actually has a part in it that would ask for MRD positivity to act with intervention purely based on MRD positivity if it was negative before. This is highly debated, whether we are at that stage yet. And the SIOPEN medulloblastoma trial includes liquid biopsy reporting just to also assess turnaround time of liquid biopsies, how many centers can actually provide meaningful liquid biopsy data, how comparable are the data across centers, etc., to then go well informed in the next medulloblastoma trial. So these are the two studies that are, I think, the closest for brain tumors when it comes to MRD.
So I know that there are clinical trials also in the adult cancer world, for sure, that look at exactly at that time point after surgery, like post-surgery, that time point saying ctDNA positive or negative, and then you see the survival curves basically split up very nicely. There, I think it's also in prospective clinical trials already, yeah, and in clinical practice for certain entities, yeah.
Any more questions from the audience?
I would take the chance to ask one question about the EVs. So I was really fascinated by your kind of elegant approach to not look for the EVs, but indirectly use the cell readout. Are you considering also looking at the cellular fraction of liquids, whether you can also find these cell responses there, or?
Well, to be honest, no, we have not really considered it. About that, we are planning on expanding this idea and also expanding it to other types of cancers, not only colorectal. And our next kind of project does aim to create these specialized biosensor cells that remain unchanged throughout forever, hopefully. And to kind of test this idea on a very large patient cohort. So we will be focusing on EVs, but it's a very great idea, to also use this cellular fraction, yeah.
Curious to see the results of that.
Well, I was wondering, so we had 4 talks all about cell-free DNA. What about CTCs? So the first instrument for counting CTCs was approved, I don't know, 15 years ago or something. I know that there has been a lot of developments in the field, but still there are the second approved instrument. Any ideas what's happening?
So I was at the CTC conference 2 weeks ago or so in Greece. And
And I was also actually working on the cell search instrument more than 10 years ago. And so the conclusion after 4 days of hearing all the CTC talks was there are so few cells in there. We are talking 10 ml of blood, 3 cells or so. And at least in the pediatric field, we can't even take 10 ml of blood. So they are thinking of doing leukapheresis and so on to get liters, basically filtering liters of blood to get all the CTCs out. And then you have many you can do genetic testing on and so on. But I'm not sure if it's, from a clinical point, feasible for many like different tumor entities. At least for the pediatrics, I don't see this happening. The children are too ill most of the time to go through procedures like this.
Yeah, I think I can only agree that with a normal blood draw, it's quite, the numbers are so low, and then also the information value, it might not represent the complexity of the disease. Nevertheless, I think these studies that are out on the leukapheresis, where you then come up with 100 CTCs per patient, I think we can learn a lot about why a tumor spreads, what are the cells that actually drive the disease, what are the changes that are required for metastasis, etc. And I think in a research setting, they might have a great value. In the clinical setting, I'm also very hesitant to see the potential there.
Well, I think it's time
Can I ask the question I actually asked Martin as well, to you as well? So do you see liquid biopsies, either EVs, cfDNA, also replacing some even a tiny part in clinical practice we are currently doing?
I don't think my answer is similar to what Martin said. I don't really think they would replace, but I'm hoping that they could come to a point where they are very complementary to tissue biopsies, as well as they maybe could be used solely for monitoring and for treatment response. And well, that is my dream of how I would want to see the future of liquid biopsies.
Yeah, I mean, I think the potential for sure is there, and I think there are clinical scenarios where we are almost there. I mean, we have, I apologize that I always come back to the brain tumors, but I think we have brain tumors that are just cannot be biopsied. And in these cases where we are dependent on liquid biopsies, we diagnose from the liquids, right? And I think there might be also other scenarios, despite having the intraoperative nanopore that is ultra fast, but we can envision a world where we take the lumbar puncture 2 days before, and the neurosurgeons can go into the operating room knowing already the diagnosis and acting accordingly, whether to be more conservative or rather gross resection. And I think there are scenarios where we might not replace the standard of care, but improve. And I think if we can make this happen, this is an important step. And I think nobody has the motivation to replace things that are already functional, but to improve where we still lag behind.
Totally agree. Okay, are there any more questions also from maybe people coming in, being super interested in liquid biopsies, or just waiting for the plenary session? So I think we can close the session here.